Hello, madam.
Hello, Mandesh.
Good evening.
Yeah, good evening. She wants to try her slide,
Yeah, she
Hemapriya. She
Hemapriya,
can,
use
yeah,
try
let
it.
us try her slide.
Yeah, yeah,
I'll share my slide now.
yeah. Yeah. Just move up and down. You will come to know.
Yeah, just move.
Yeah. Should be okay. Yeah. Should be fine.
Yeah, it's okay.
Madam, how
Yeah.
are you?
Yeah, how are you, Mandesh? I'm fine. After a long time, I'm seeing you.
Yeah. I get updates from you from Dr. Sonali.
Sonali, yes. She's there. She
She's
joined
in
back
our
after
unit. Yeah.
in
Attend-
your unit? Is she?
She's in our unit. Me, Man Shetty madam,
Okay.
are in the same unit.
Okay.
She tells that you're the very busy with the dean thing.
Yeah.
It's very difficult to manage all women.
Yeah, it's difficult. Juggling between so many things. Manchadi madam is principal, no?
She's principal, madam. She's principal.
Yeah.
She's also involved in.
How is VD Patil, sir? How is VD Patil, sir?
Sir is fine. He's in charge of the hospital, madam. New hospital projects which are going on. So
In Kaili?
Yeah. So
Of Kaili?
yeah, they have started in Hubli one new medical college.
Okay.
So he was responsible for that starting of the new medical college in Hubli. So
in Hubli.
So like that, one hospital they have started in Pune, which they already outsourced it.
Yes, I know that Medicare.
Correct. Like that, many
Correct.
bits they are.
Okay, satellite.
So he travels, a lot of traveling he does.
Oh,
Hope
so he's in good health. No problem.
he keeps himself.
Yeah.
Hmm. You still take classes, madam, at the.
Yeah. I know. I take means we PG clinic program. I'm not very regular now. But I go for my rounds,
Okay.
OPDs.
Okay, good.
Mm.
Evening clinic and all you don't do, madam.
Evening we don't have. We have one on Fridays every day morning. Mm.
No, private clinic you don't do, madam.
No. No. I don't have private clinic. Oh, I thought. Yeah. You have Mindesh? Yeah.
So now I'm in my clinic only. I just finished early today. So usually by 9:30 I
Right.
finish usually.
So whole day is busy. Whole day is busy for you, no?
Whole day is busy, madam. Quite busy.
Do you do pediatric transplant in KLE, renal?
This year we did two, madam. One was in March and one we did in September.
Okay.
Now one more is planned in
Okay.
November. It's planned one more.
Hmm.
Very stressful because
But it is on any.
we had done
No, it's paying patients or
paying patient, ma'am, paying.
paying?
So yeah, if they require those patients who require dialysis, we have our free dialysis ward, madam. So we keep them in the free ward until transplant.
Okay.
And then shift to the for transplant. So in March we had done like that. In September we did a preemptive transplant before going for dialysis. So and now one more is there in November. So they are.
What were the ages? What age?
One
What age?
March one was 15 years. Then September she was 17 years. Then yeah, one November, madam, 9 years. He's 9 years. Bit stressful because I don't have a team. I'm all alone now. So bit stressful. It becomes very stressful.
Okay.
The surgeon just operate and go, and rest all we only have to do before, pre, post, and
Yes, surgeons, na? Surgeons. Yes.
very stressful. You all have increase in the seats, no, madam? That's what I heard. PG seats, pediatrics.
You can stop sharing now, Hemapriya.
Sorry, ma'am.
You can stop sharing now. We'll start later.
Okay, ma'am. I'll start presenting now, ma'am.
No, stop sharing now. We'll just,
Stop.
we will tell you when to share.
Okay.
Stop sharing.
Just wait a couple of minutes, few people to join. So, okay.
Okay.
How much do you charge for the transplant?
Here there's a package. We give around 8 lakhs for total
8 lakhs. Okay.
total 10 days stay, and it includes
10 days.
all the immunosuppressives also, and medications and and nowadays the immunosuppressives is also very cheap, madam. We are getting
okay.
very less.
Yeah. Otherwise, that was costly. So,
That was
no?
very expensive.
Expensive.
Many companies have come in, so they give at a very less price.
In Mumbai now, Sion they do, I think, free, no? Almost.
In Sion, madam. For pediatric or adult?
No, I think somewhere, yeah, adult or no, children, I don't know, pediatric. At I don't know where Umali madam is doing somewhere. It's at a little subsidized.
But many times, madam, we have to go after transplant. We have to go very clinically. We cannot rely much on the investigations. Like for example, the EBV, CMV.
Yeah.
It's very expensive, so we have to go very clinically and assess, and then see if they really require. Otherwise, it becomes very expensive.
Good evening, all of you.
Good evening,
Good
sir.
evening, sir.
Good evening. Yeah.
Good evening, sir.
See you, Srinivas, sir. After a long
nice.
time.
Yeah.
How are you, sir? Thanks.
Sir, are you back or still in the US?
No, I have come back long back. Yeah. Good evening, Dr. Ramakrishna, Subramania, and Dr. Mayanish
Good evening,
Patel.
sir. Good evening, sir.
Good evening, sir. Good evening, sir. Hello, sir.
Welcome.
Shall we
welcome,
start?
Antesh.
Subramania, start?
Good evening,
Yeah,
everyone.
yeah,
Good
we'll start.
evening,
Shall we start? It's 9 o'clock. Yeah. Please give the opening remarks, Subramania, sir.
Okay.
Good evening, sir.
Respected viewers on DIP platform, our dear postgraduate students. In fact, it gives us great pleasure wishing you happy Navratri from all of us. And may that Saraswati Puja will also give all the postgraduates the blessings of the Ma Saraswati and all of you, flourish with flying colors in your life. That's what as teachers, myself, Sarah Madam, Ram Krishna, Chinivasan sir, all of us would wish the students. And may I also take this opportunity on behalf of CAP, Dr. Upendra Kinjwadekar, Vinit Saxel, our own colleague from Belgaum, a professor of nephrology, and also Hema Priya, who is a young postgraduate who is presenting the case today of a difficult to treat nephrotic syndrome. Let's see how the case gets unfolded. But all that I would wish is that every one of you, after participating in the teaching program, see that there should be recruitment of all the other postgraduates in the same institution for each other program to follow. So that's what we would wish that would get cascaded, and ultimately in 3 or 4 years from now, the postgraduate clinics would become a passion as well as mission, and the vision of the CIAP should get ultimately achieved. So I also welcome Dr. Balasubramaniam sir. Greetings and most welcome to you. I think with looking at the faculties who are all joining in, it appears that there must be some difficulty in treating nephrotic syndrome. So it appears that even all teachers also are eager to learn from you. That puts, I think, Haripriya under a little bit of tension, but don't worry. Gold medal is assured to you, only that you have to present the case.
Sarah,
Sir?
ma'am, you take over.
Yeah,
You
And
take
back to
over.
Sarah Madam and Ramkrishna.
not clear.
Dr. Subramania, you are not clearly audible.
Yeah, you're not audible.
Sarah, ma'am, you proceed.
Yeah. I would just briefly introduce today's expert, that is Dr. Mahandesh
For
Patil.
taking over.
He's
No.
professor in pediatrics and head of pediatric nephrology division at Jain Medical College and KLE's Dr. Prabhagar Kore Hospital, Belgavi. He did his fellowship in pediatric nephrology from St. John's Hospital, Bangalore. Subsequently, he also had training in National University Hospital, Singapore, and Sick Kids Hospital, Toronto, Canada. His areas of interest are nephrotic syndrome and kidney transplant. So today, I think we will be concentrating more on the treatment aspect of nephrotic.
Got muted, ma'am. Got muted.
We come across in treating the nephrotic syndrome, especially when they do not respond to steroid the way we expect. So I'm sure it's going to be a useful session for the postgraduates. And Dr. Ramakrishna sir just messaged me saying that we should also discuss about how to treat the steroid responsive nephrotic syndrome also. So I would request Dr. Mahandesh to touch on all these points as the case evolves. Over to you, Haripriya. You can start sharing your screen now and start presentation.
Good evening to one and all. Today I'll be presenting a case on how to approach a difficult to treat nephrotic syndrome.
Your voice, Hemapriya, your voice is breaking. Yeah, start. You can start, Hemapriya.
So am I audible now?
Yeah, continue.
Okay. Good evening one and all. I'll be presenting a case on how
Your voice is breaking.
Yeah, your voice is breaking, Haripriya.
You can continue.
No, Dr. Patil, sir.
Yes, sir.
It may take some time. You may give some introductory remarks regarding this.
Okay, sir.
Yeah, you can just start.
Broadly. Yes,
Yeah.
yes. Broadly, not
Okay.
about the case exactly.
Yeah, so in the recent times, the changes that have occurred in the scenario of nephrotic syndrome cases being coming to us has changed over the last few years. Earlier, they used to be very what you call very responsive and very they used to respond early, and we used to have very less relapses. But the trend has changed over the last few years, and more emphasis has been given to counseling of the patients. I think Hemapriya, you can start.
Yes, sir. I'll start with
Just a minute, Doctor.
Yes.
Probable reason, sir?
The reason for the change in the way we see that changes has occurred is, I think, the exact reason still is not clearly understood, but still that immune mediated responses are changing a lot. The T lymphocyte functions and those, so many things have come up in the recent TH receptors. Those have come up recently in the new phase, which has changed a lot in the in in managing these cases.
Okay. Dr. Haripriya, right.
I'll be starting now. So coming to the patient details, patient name ABC, 8-year, 8-month-old male child, born out of a second degree consanguineous marriage. He was a second born, and informant being the mother, and she is reliable. The child is a known case of kidney disease, that is nephrotic syndrome, and now he came with complaints of fever since 4 days and complaints of increased breathlessness for 1 day prior to the admission. Coming to the history since the onset of disease. So the child presented at 4.5 years, that is in November 2018, where the child had an episode of fever and loose stools, following which he developed periorbital swelling, puffiness of around the eyes, followed by abdomen distension, and then followed by the lower limb swelling over gradually over a few days. And then the child was detected to be having nephrotic syndrome, and he was started on oral medications, following which the swelling gradually resolved, and he was advised to continue the medication for 2 months, and later on it was stopped.
Yeah, Haripriya, I'll just stop you here. So
yes,
before we just go back to the previous slide. Yeah, so no, next slide.
No, in this slide only, just a minute, sir. Dr. Haripriya, you are mentioning increase in breathlessness. Was the child breathless in between?
Yes, sir.
Sir, you are not audible.
Breathlessness.
Right. No, you were telling increased breathlessness.
Yes, sir.
In between, the child was having breathlessness, or only just a grammatical point, that is?
Sir, he had history from past 9 months where he was breathless, which increased in past 1 day.
No, he had been breathless for the last 9 months.
Yes, sir. On and off, he was being admitted, which I'll be telling in the subsequent slides, the overall history.
Okay,
of,
okay.
Yeah. So Haripriya, just let us know how clinically are you going to diagnose nephrotic syndrome. This is a UG question, so you
yes,
tell us quickly. Clinically, how do you diagnose a case of nephrotic syndrome?
So usually, the age of onset is between 2 to 6 years, which we usually find in children. So the child presents with gradual onset of edema. It progresses from periorbital edema, facial abdomen, then lower limbs, which is classical of the nephrotic syndrome. And also it will be initially more in the morning time, and then over as the day progresses, the edema will resolve. So this is one thing. And previous to that, there will be history of some infection which will be leading to development of this edema. So then we will have to suspect nephrotic syndrome.
Okay, so just a slight change here. It was first thought to be 2 to 8 years. There's a slight change. The age has been now started from 1 year onwards. So it starts as early as 1 year. So less than 1 year, you call it as what?
Congenital nephrotic syndrome.
No, less than 1 year and more than 3 months.
Okay, less than 3 months is congenital nephrotic. Right. More than 3 months, less than 1 year is infantile nephrotic syndrome.
After 1 year, you say it as
classic onset nephrotic.
Childhood nephrotic syndrome up to the age of 12 years. Okay, so that age group has been changed slightly. That is one which you should remember. And as you said, the classical symptoms of periorbital edema. What is a classical feature in nephrotic syndrome, which is not there in some other diseases like glomerulonephritis? What is the classical picture you get in nephrotic syndrome, apart from the periorbital swelling?
So there will be reduced urine output, but there won't be any hematuria present.
Apart from that, what apart from edema of the face, where else they have?
They have edema in abdomen and pedal edema. Pitting pedal edema will be present, sir.
Yeah. So the earlier term was they have something called as generalized anasarca. So generalized anasarca is a very typical feature of nephrotic syndrome. So they can develop third spacing. So where all third spacing occurs?
One is in the pleural cavity, peritoneal cavity.
Good.
And also in the like interstitial edema, which can cause like the fetal edema and all.
Total. Okay.
Total edema.
Yeah. So this is a classical picture of nephrotic syndrome clinically. How to diagnose? Okay. What are the basic investigations you will do to diagnose nephrotic syndrome apart from clinical?
So like a diagnostic investigation. Sorry, sir.
Start with basic investigations.
Basic, we will do a urine routine microscopy to look for like the proteinuria. So ideally it will be 3+ or 4+ proteinuria on dipstick. And also like we will see for the like serum albumin that will be reduced in nephrotic syndrome due to the protein loss. And
how much?
Also
how much serum albumin will be?
So like it will be less than 3 grams, sir.
Good. And the urine, what you said, which sample?
Urine protein creatinine ratio, spot urine creatinine ratio we will see, sir. The ratio will be more than 2.
Good. Which sample? Afternoon, evening? Which sample?
Early morning sample we will take, sir.
It should be early morning sample, and it should be how much? It's that there's a term which is used. It's not just proteinuria. There's a term which you should use. What is that term which is called?
Which indicates that there is significant glomerular and tubular disease. What is the prefix for the proteinuria?
Neph starts with neph. Nephrotic
range proteinuria.
Okay, so it should be nephrotic range proteinuria, which should be more than 3+. Okay, if it is 1+, 2+, is it nephrotic syndrome?
No, sir.
Yeah, it should be at least 3+ on just one day.
3 consecutive days, it should be 3+ or 4+.
And you said about blood investigations.
Yes, sir.
Which is that? Serum albumin. Anything else?
Serum cholesterol levels will be elevated, sir. It will be more than 250.
Yeah. So I just want to put in a word. The recent guidelines have changed a bit. The serum albumin level of less than 3 and urine showing 3+ or 4+ is enough with edema to diagnose a case of nephrotic syndrome. Earlier it was serum cholesterol, but the ISPN, Indian Society of Pediatric Nephrology group, in 2021 has changed this. Serum cholesterol may not be required to diagnose a case of nephrotic syndrome because it invariably will be elevated. So only these criteria are enough to diagnose case of nephrotic syndrome. Okay.
Dr. Hampriya.
Yes.
Here, anasarca is preceded by fever. In acute glomerulonephritis also, there is precedence, fever will be there. What's the difference?
The difference is in like
vis-a-vis fever.
Sorry, sir?
In relation to fever,
yes, sir.
patient is facing nephrotic and the other one is nephritic.
Yes, sir. So in nephritic syndrome, the fever and throat pain will be there or some skin infection, which will be like ideally 2 to 3 weeks prior to the onset of the symptoms. Whereas in nephrotic syndrome, the infection will be there and the child will start presenting with proteinuria within few days only, sir.
And that is a bacterial infection having signs of bacterial infection. Here it is mostly viral. Right.
Viral infection.
Okay. Carry on. Move on.
Then the following this, the child had 3 similar episodes in the next year, that is in 2019, and 2 episodes which were within 6 months following the first episode. So every episode here was precipitated by an infection, which was upper respiratory tract infection. Every time the child would be given prednisolone and the swelling would come down. And then the 4th episode was in Jan 2020 when the child's age was 6.5 years. Then like after that there was lockdown and the child had lost a follow-up and like at home the prednisolone whenever the swelling would increase and she would herself increase the dose and decrease the dose. So like in 2020, the child had 2 to 3 episodes, and 2021, we had 3 to 4 episodes of nephrotic syndrome.
Hey, Priya, in this slide, there are many things which need to be understood from this slide. Okay. First is, how do you treat a case of first episode nephrotic syndrome?
So first episode of nephrotic syndrome, we start with oral prednisolone. So we start with either with the body weight or body surface area. So according to body weight, we will give 2 mg per kg, or according to body surface area, we will give 60 mg per meter square for like 6 weeks. Following that, we will give alternative prednisolone, which is like 1.5 mg per kg, or like 40 mg per meter square body surface area for the next 6 weeks, and then it is stopped, sir.
Yeah. So this is being endorsed by the Indian Society of Pediatric Nephrology Group 2021, which we all follow. Okay. There is one more consensus which says that, you know that, or should I tell it?
So it's like 4 plus 4 weeks, sir.
No,
so
that was old. That was old. So the first thing is 6 plus 6 weeks. Okay, body surface area. So what is the maximum dose? Suppose if the weight is around 40 kg. So if you go by
60 mg is the maximum dose.
how much?
60 mg.
Yeah, 60 mg is the maximum. You can't go beyond that. So if the body surface area dose is high, you go for body surface area dose. Or if you find that the weight is high dose, you go by that. Now there is less than 4 to 6 years of age, you can go by a prolonged therapy, 6 plus 6 plus, so 24 weeks for those who are less than 4 to 6 years of age. The reason what has been given by the KDIGO, that is Kidney International Disease Classification, says that the number of relapses which occurs. So what is the rate of relapse after the first episode is treated? Any idea? You treat first episode of nephrotic, what is the rate of relapse?
No, before that, Dr. Hamapriya, was there compliance at least first time, second time, and third time?
Sorry, sir?
Compliance in following the advice, in giving the medication. Did
Yes,
they give
sir,
full course, or they have stopped in between?
No, sir, they have taken the full course, sir.
At least first 2-3 episodes.
Yes, sir. First episode, he has taken the full course. Second and third also. After that, when there was lockdown, he lost to follow-up.
But you were mentioning 2 months only. It was 2 months only they have taken. They had taken.
Sir, like, initially, he took the full course, and following that, 2 months he has taken, sir. Like after the first 2 weeks plus like next 2 months he has taken, sir.
Why I'm asking is to brand it whether it is steroid responsive or steroid dependent. We have to have good history, isn't it? We decide by that only, right? Okay.
Yeah. So first episode will be treated 6 weeks plus 6 weeks. You have one more option, less than 6 years of age. You can prolong the therapy to 24 weeks by giving 6 plus 6 plus 6 plus 6. Okay. So this is for first episode of nephrotic. From this slide, does this child have frequent relapses or steroid dependent, and how do you define it?
So frequent relapses is when like the child has like more than or equal to 2 relapses within the first 6 months of the first episode, or more than or equal to 4 relapses within 1 year.
So here,
here he had like 2 episodes within the first 6 months, so it's a frequent relapse.
So you say this as frequently relapsing nephrotic syndrome. Something else you want to add to frequently relapsing nephrotic syndrome? You have told in your slide one important thing.
It was always preceded by an infectious etiology.
Correct. Always preceded by a upper respiratory tract infection. Okay, so this child has got frequently relapsing nephrotic syndrome. Okay, so this child is steroid sensitive or no?
Sir, he was steroid sensitive because up till now he was steroid sensitive, sir, because when they would increase the dose, then he would respond to it, and then after like tapering, he would be like in relapse, and then later on when there was an infectious etiology, he would again present with nephrotic syndrome.
what are the other infections which you would like to take into consideration when they relapse? Apart from upper respiratory tract infection, which are the other infections which the child of nephrotic syndrome on steroids can have?
So they are
Name.
more prone to like encapsulated organisms infections like streptococcus pneumoniae. So we should think of spontaneous bacterial peritonitis, then pneumonias, recurrent pneumonias, and also we should think of cellulitis.
Anything else? If they come with
Tuberculosis also should be suspected in children. And
that is recurrent. No, anything else? Any common? Like first you said upper respiratory tract infection, then you said about lower respiratory tract infection, spontaneous bacterial peritonitis. You said anything else? Any if they complain of burning micturition? If a child complains of burning micturition, what you should suspect?
UTI.
So that should come. And any other infections of the lower limb they are prone for? Lower limb, if they have pain of the lower limbs.
Cellulitis, DVT.
Yeah, you should think of cellulitis. Calf muscle tenderness will give you indication of
DVT.
Okay. You can continue.
So next again in October 2021, child was noted to be having high BP recordings. Like when he had come, this was the first time when he came, and he was noted to be having high BP recordings, and also his eye examination showed changes due to high blood pressure. And he was advised renal biopsy in lieu of persistent proteinuria despite taking prednisolone, and also because of hypertension. But the attenders refused at this point of time. So he was put on oral medications. And then again, later when he came for follow-up in November 2021, he was started on a new oral medication for the nephrotic syndrome, and prednisolone was continued for a few days. And later on, the levodopa was added for the child.
Okay, now here you're saying that the child is having high blood pressure recordings. Tell me some causes of high blood pressure in a child of nephrotic syndrome. Why a child of nephrotic syndrome should have high blood pressure?
One reason could be because of the long-term steroids which he has used, and like the dosage also like was high, and for a prolonged time he has used the
So it's called as steroid toxicity.
Steroid toxicity.
Okay, that is one.
And then one more
Neither
thing
reason
can be because of the ongoing renal disease process which is causing hypertension in him. Or one more reason could be because like there is fluid retention. Again, it could be in relapse causing fluid retention that would have increased the intravascular volume and caused hypertension.
So you said first was steroid toxicity causing high blood pressure. Second reason you gave was the ongoing nephrotic. So can in 85 to 90% of the case of nephrotic syndrome, what is the renal pathology?
So it is the minimal change disease, which is the most common.
Correct. So in minimal change disease, do you get hypertension or no?
No, sir.
Yeah.
No,
so
sir.
if you're thinking of ongoing progressive renal damage, which are the other diseases of nephrotic syndrome which can cause high blood pressure?
So, FSGS, focal segmental glomerulonephritis, membranoproliferative glomerulonephritis, then mesangoproliferative, membranous nephropathy.
So you need to think about these. Like if a child was being treated with steroids for a long duration, steroid toxicity, the first important thing to say, if the blood pressure is high, you should rule out that. Second thing, as you said, the other progressive diseases like FSGS. And so here we have told about renal biopsy. Can you tell here what are the indications for renal biopsy in a child of nephrotic syndrome? Why we need to do renal biopsy in a child of nephrotic syndrome?
So one over here is because like the child was on like oral prednisolone. Despite that, he was having
not here. In general, what are the indications of renal biopsy?
One is like persistent proteinuria despite on prednisolone. That
Clinically,
will be
so
like
see, always go clinically first and then go based on lab investigations. Clinically, when you see a child suspecting nephrotic syndrome, what are the indications where you have to do a renal biopsy clinically?
so when there is like persistent hypertension, even when we stop prednisolone. So, and then later on, like there is like persistent edema in the child, and hematuria is present in the child.
Microscopic or gross?
Gross hematuria and also microscopic hematuria also we will have to recurrently do urine routine microscopy. If there is persistent microscopic hematuria, even then like we will have to do renal biopsy.
So first is gross hematuria. Okay. Then second is if there is clinically rash, if there is rash associated with edema, arthralgia. So there is, these are called as extrarenal features. You should keep in mind. So child with nephrotic syndrome features having extrarenal features like rash, arthralgia, gross hematuria if it's there. Microscopic hematuria, you want to do just once if the child is having, if the urine shows RBCs, or what is the criteria of that microscopic hematuria? You said persistent, no? So how long?
Persistent hematuria is when over the next 3 weeks, every consecutive samples to be taken. 3 samples should show like microscopic hematuria with RBCs of more than 5. So.
What is the percentage of microscopic hematuria seen in a case of nephrotic syndrome? What is the percentage? Yeah, so in 10 to 12% of the cases of nephrotic syndrome, you will get microscopic hematuria. So you need to send a fresh centrifuge sample of and see for more than 5. But if it's persistent in the sense not just 3 days, it should be persistent for nearly 4 to 6 weeks, persistent. But if persistent, if there is microscopic hematuria in the presence of rash, arthralgia, that's the indication. But isolated microscopic hematuria in 10 to 15% of cases, it's known in nephrotic syndrome. That is not the sole indication to do renal biopsy. Okay, so first is gross hematuria, extrarenal features. Third, persistent hypertension at the onset of, before you start steroids, before you start the child whom you are diagnosed to have nephrotic syndrome, before you start the child on steroids, if there is persistent hypertension, because hypertension is not a feature of minimal change disease. Yeah. So before starting steroids, if you find that the child is having hypertension, this is another indication where you have to do a biopsy. Then any other, then lab features. Okay. So lab features, I told you, if there are altered renal functions, normal 80% are minimal change. So you don't have altered renal functions. So if the renal functions are altered, you should keep in mind. Anything else? Any other? Once you start treatment, what is the indication to say that the child is not responding to your daily dose of steroids? When do you say as steroid resistant? This is a very important thing which you should understand.
Even after giving the whole 6 weeks of steroid prednisolone to mg per kg, if the child is still having persistent proteinuria of 3+ to 4+ for 3 consecutive days, then we label it as steroid resistance.
You want to add something else in this, because you should not take steroid resistant so easily that 6 weeks they are not responding, you say it as steroid resistant. No, it has to be taken in a very deeper context. You have to be very, very, very sure that it is, they are not responding. So what else you need to ask in the history, as sir was asking you regarding compliance, that's a very, very important thing which you should ask. Compliance. If 6 weeks compliance has been taken or no. If even if 3-4 days, if the child has not taken steroids and in the right dose, you should not say it as steroid resistant. One. So compliance is a very important thing which you should ask. Second, dose. It should be 60 mg per meter squared or 2 mg per kg, whichever is higher. Third, any other criteria to be fulfilled before you say it as steroid resistant. I'll tell you why we have to take this as a very important thing to label a child as steroid resistant. Third is what? What is the third criteria? During the course of the 6 weeks daily, what should not be there?
There should not be any infectious precipitating infections in the child.
Right. There should not be any precipitating infections like upper respiratory tract, or if the child is suffering from tuberculosis. Okay, if your child is suffering from tuberculosis, that should not be there in this 6 weeks. So compliance, right dose, no intercurrent infections. Why so much strict criteria has to be taken before you label a child as steroid resistant? And it has been told after 6 weeks. Why so much strict criteria has been applied? Do you know?
So in the studies done, like they showed if they were giving it for only 4 weeks, the relapses were like more. So
No. Why the strict criteria of 6 weeks, and why this strict criteria has to be taken into account? Compliance, dosage, no intercurrent infections. Why? The reason is this steroid.
Himapriya, can I ask you one question? So,
Yes.
Mahandesh?
Yes, madam.
Hello?
yes, ma'am. Yes, ma'am.
Yeah. I want to ask Himapriya, what is the average time? When do you expect them to respond? A typical minimal change nephrotic syndrome after starting your steroid. When do you expect them to respond?
They respond by like around 2 weeks, ma'am. They respond. The proteinuria comes down, and the edema also comes down by like 2 weeks.
Yeah, that's why I'm asking when normally when.
No, she
Yeah.
told
Okay.
already. Yeah.
So the Mahandesh is asking why there's 6 weeks.
Yeah. So as you said, 2 weeks, but there's something called as early response. Okay, so early responses within 2 weeks of starting steroid therapy, they should have adequate reduction in the edema and proteinuria should come nil. This is early response within 2 weeks. There is something called as late response. Late response is after
6 weeks they respond.
No. Late response is after 2 weeks. 2 weeks. They respond. See, there is two things. Early response and late response. Early response is they have to respond within 2 weeks, where the edema should subside, proteinuria should be nil. It should be nil. That's the criteria. It should be nil. This is early response. Late response is when they respond, but they respond after 2 weeks, where the edema subsides, the proteinuria becomes nil. This is late response. Response is there, but it's late response. Now there's one more entity which you told steroid resistant. That is up to 6 weeks. You have to wait. Now why we should wait for 6 weeks and why the criteria has to be fulfilled is once you label a child as steroid resistant.
Mandesh, your voice is breaking. I don't know. There's some instability, I think.
Yeah.
Net.
Now, madam, now it's clear.
Yeah. Ramakrishna sir, can you hear audibility?
Now it's clear.
Not very clear. Right.
Not very clear. Both of your voice some. So just see
also,
because I think it should.
So
you may just
little bit the voice.
I am able to hear clearly.
Okay.
Can you just?
There is no problem with Mahantesh's voice. There is a problem with the Himapriya's. Only voice is going and.
Probably you may log out and
Echoing in that area. Probably using two instruments.
Priya, I think log out.
Put off your phone, cell phone, probably which is nearby and somebody is using it.
Correct. Yeah, so the steroid resistant, once you label a child as steroid resistant, we have very less options of treating the child. the immunosuppressive medications which are used are there, but there are hardly any much responses once you say it as steroid resistant. The progression to chronic kidney disease is much more, and you have to be very careful when you say a child is steroid resistant, because child has to undergo biopsy, and then we'll see later on which are the drugs which are used. Okay, so you have to be very careful when you say it as steroid resistant. Can continue.
Sir, just one comment.
Yes, sir.
In addition to microscopic hematuria, as you rightly said, it is believed that 10% of nephrotic syndrome might have hypertension, 10% of nephrotic syndrome may have microscopic hematuria. In addition to microscopic hematuria, if you happen to do a C3 and the C3 is persistently low, you should think beyond minimal change disease, consider renal biopsy. That's just one. Second, holistically, if the clinician feels that this child does not appear to have minimal change disease, holistically, not, of course, all the criteria you mentioned. On the whole, if the clinician feels for some reason that this is not minimal change disease, which may include steroid non-responsiveness, it may include some signs of a multisystem disease, which may include hypertension, which may include lower age, it may include non-responsiveness, or which may include something which is suggesting to the clinician that this is not minimal change disease, you should consider renal biopsy. Last but not the least, in the presentation for the first time, a child with nephrotic syndrome is never an ill child. Never an ill child. It's very, very unusual for somebody to see for the first time a child with nephrotic syndrome, one who's acutely ill. So acute illness in nephrotic syndrome presenting for the first time, think beyond minimal change disease. Thank you.
Thank you, sir. Thank you, sir.
I'll be continuing. So despite giving oral medications, the child had proteinuria and hence was again advised for renal biopsy. So in Jan 2022, renal biopsy was done, which showed focal segmental glomerulosclerosis, about 13.6%. And hence he was started on cyclosporin. And later on, the child had frequent hospital admissions for lower respiratory tract infections, spontaneous bacterial peritonitis, and also high-grade fevers. And again, he was admitted in November 2022 with LRTI and pleural effusion, which was treated conservatively by giving IV antibiotics, and then he was discharged.
Yeah. So here, Hemipriya, can you tell us what is the treatment, or how do we proceed to treat frequently relapsing? You told the definition of frequently relapsing. How do you treat frequently relapsing nephrotic syndrome?
So frequently relapsing nephrotic syndrome, we can continue giving the steroids if they develop steroid toxicity, or in case even if though they are on steroids but they are developing severe infections, then we will have to switch over to the steroid sparing agents like levemosol, MMF, or
we start with one drug. Start with one drug. First drug is which is the first drug which we use for frequently
Levemosol.
Levemosol. Good.
Levemosol is the first.
What's the dose? What is the dose?
Dose is 2 to 2.5 mg per kg on alternate days, sir.
For how long?
It can be given for around 1 to 2 years, sir, along with prednisolone initially. Then the prednisolone dose will be tapered, sir. It can at times even the prednisolone can be tapered and stopped also, or a low dose of steroid can be continued along with the levemosol.
Can you name some side effects of levemosol?
So levemosol, it causes GI side effects, and also it causes immunosuppression. So we should be doing the total counts routinely, and other side effects of levemosol.
Yeah, I'll just tell you here, that the books mention that it causes slight bone marrow depression, so we have to do frequently blood counts, but it's not so. We have many patients where we treat with vermisol, so it's the most safest immunomodulator. It's a very, very mild drug, but if we use it very carefully, it works wonders. So you should use it. You should be careful when you use levamisole. One important thing which you should keep in mind is it is used only for frequently relapsing and for those who respond to prednisolone. So if a child is having relapse, can you use vermisol?
Yes, sir. If it is like a steroid
No, if a child is having relapse, how do you define
no,
relapse?
sir. In relapse, we should not. We should like attain a remission, then start on the levamisole.
Correct. So relapse, when a child is on relapse, 3 plus or 4 plus proteinuria, you cannot use levamisole. It will not work. It has to be in remission, and it has to be given for a longer duration, 1 to 2 years. That's the first drug which you use for frequent relapses. Any other drug which has been recommended which can be used?
MMF can be used, sir.
What's the full form of that? What's the full form of?
Sir, just 1 minute, sir.
Just a minute.
Sorry to interrupt you. Shall we first complete the presentation, then we may discuss the management?
Okay. Okay.
Because this is PG teaching. Sorry to interrupt you. It is not for the nephrology fellows or nephrology DM candidates where the discussion may go like this. Right, sir? With due apology. Right.
No problem.
Right. Carry on. Priya. First, we will finish off.
Continue here, Priya.
Again, in July 2023, he was admitted with history of breathlessness, which was insidious in onset, and progressed from he was initially he was breathless when he was walking, which progressed to breathless even during rest within only 2 days of duration. And he was admitted, and he was told he had accumulation of fluid in the both sides of the chest, and pleural tapping was done, following which the distress was reduced. So in the pleural tap, the fluid was noted to be thick, milky white in color, which was about 300 ml on each side. And IV antibiotics were given to the child, and then the child gradually improved and he was discharged.
But Shamapriya, what's your take? Why it's milky white?
So
Generally, it will not be. Generally, you don't expect that altered appearance, isn't it?
Yes, sir.
Normally, what is the appearance? We don't
It
take
can
the
be
fluid
straw,
out, but what
be-
it will be? It will
It
be,
can be clear or straw color fluid, sir.
because it's a transudate generally. Then what's your take when it is white in color?
It is exudative. Either it can be empyema, or it is milky white and thick. It can be chylothorax also, sir.
No, you said milky white means you don't think of empyema, right? Chylo, right.
Chylothorax.
Is there any explanation why it is milky white?
Because of the fat, so the chylomicrons which is present, that gives it a milky white
Why
appearance.
it has occurred in this scenario? That's what I'm asking.
So one thing, the child is a known case of nephrotic syndrome on immunosuppressants for a long period of time. So there can be tuberculosis which can be causing chylothorax, because tuberculosis is also known to cause chylothorax. Or there can be some obstruction to the thoracic duct, so which is causing this chylothorax.
Dr. Mahantesh, your comment.
Yeah.
Also this milky white.
Yeah. So you should know the causes of milky white color. So as you said, non-traumatic causes are very important here. And one of them you said was tuberculosis. Any other causes, as you said, could be blockage of the, can be even, you should rule out malignancy in some of the cases. Okay? Yeah, in some of the cases. Okay.
Just one
Not
comment.
Subramanian, right.
One comment. 2 things. If chylous pleural effusion is occurring on both sides, infection unlikely. Is more likely to be due to a lymphatic obstruction than due to an infection. There is what is called pseudochylous ascites, which can occur in infections like tuberculosis, but it never occurs bilaterally. Of course, tuberculosis can cause chylous ascites
So it is a refusion you are referring to.
Effusion,
Cause
effusion.
of thoracic duct obstruction due to lymph nodal tuberculosis. The other condition which you have to think of, how rare it could be, particularly in nephrotic syndrome, one of the causes of course, Sir Mahashet will know, is lymphoma. It's one of the most rare causes of nephrotic syndrome. And you give steroids, everything melts and the nodes come back and they compress the thoracic duct and they can cause chylosositis. Last but not the least, any infection starting from empyema can cause pseudochylosositis, including pneumococcus, but that doesn't occur bilaterally. Bilateral infection unlikely, obstruction most likely, rather than primarily infection. And the cause for the obstruction we have to determine.
Can proceed on the next slide. She has
Move on, fast.
move on to the next slides.
Now, after 20 days after the discharge of the child again came with complaints of fever for 4 days, which was high grade continuous fever relieved on taking medication. It was not associated with chills, rigor, or rash. And he had complaints of breathlessness, which progressed from breathlessness during walking to breathlessness even at rest in only 1 day during this time. And there was history of orthopnea, and there was no history of chest pain or palpitation, no history of pedal edema, increased abdominal distension, facial puffiness, or decreased urine output. There was no history of cough with expectoration or hemoptysis, and there was no history of any trauma to the chest, and there was no history of any headache, blurring of vision, or altered sensorium. So, the chest pain and palpitations I had asked because, like, if the child had any like CCF features, then also there can be bilateral pleural effusion and the child can present with the breathlessness. So for that, like to rule out IDAS and pedal edema, increased abdominal distension. All this is because of, again, if the child had gone into like a relapse. So again, then there can be like a massive proteinuria and leading to anasarca. That time also with bilateral pleural effusion, the child can present. In cough with expectoration and hemoptysis, I'd asked because like previously also the child had come with history of pleural effusion and there was milky white fluid which was seen on tapping. So to rule out to look for any history suggestive of like tuberculosis, I had asked this history. And history of trauma to the chest, even like trauma can be also one of the cause of like chylothorax. And also headache, blurring vision, and altered sensorium, I had asked to look for like steroid toxicity.
Excellent.
Coming to the past history, at 3 years, he was diagnosed with tuberculosis and he had taken ATT for 6 months. After that, he was completely cured. And there was no history of any other known comorbidities. Antenatal and perinatal history were uneventful. Immunization history, he was immunized till 1.5 years according to the National Immunization Schedule. 5 years DPT booster was not taken in view of recurrent fever episodes and edema episodes and recurrent hospital admission, so it was not taken. Pneumococcal, meningococcal, influenza, and varicella vaccines are not taken. Developmentally, he was normal. There was no delay or regression. Currently, he is not going to school from past 1 year in view of repeated hospital admissions. Coming to the nutritional history, he has a deficit of 300 kilocalorie and a protein deficit of 8 grams. Family history is a second child born to a second degree consanguineous couple. There's no history of any genetic disorders in the family or no history of any kidney diseases in the family. Socioeconomic history, he belongs to upper lower class according to the Kuppuswamy classification. Coming to the summary of the history, a 8-year, 8-month-old male, second born out of second degree consanguineous marriage with normal antenatal and perinatal history and normal developmental history with incomplete immunization status with nutrition deficiency, belonging to upper lower socioeconomic class with history of tuberculosis at 3 years of age and the known case of nephrotic syndrome from 4 years of age with frequent relapses and frequent infections and steroid dependence. Later on, he developed hypertension and side effects of long-term steroids, and he later became unresponsive to steroids and hence underwent renal biopsy, which showed FSGS, following which the child was started on cyclosporin, and now he has recurrent severe infections requiring ICU admissions with a history of recurrent episodes of pleural effusions. So the system involved are the respiratory system and the renal system. So the nature of the disease is acute and chronic. The probable etiology being pleural effusion secondary to either empyema, tuberculosis, or chylothorax.
What was the compliance for ATT? Any
So
idea?
he had taken complete 6 months. After 6 months, he was tested and he had the reports given from the government.
For 6 months, there was good compliance?
Yes, sir.
Right.
What kind of TB? Was he microbiologically diagnosed or what's the clinically diagnosed tuberculosis?
Clinically diagnosed, ma'am. And then like ZN staining, it had showed like positive. He didn't have any reports of the CB NAT done.
Okay. Did the child have a BCG scar?
Yes, BCG scar. He was immunized, ma'am.
Okay.
Dr. Srinivasan, your comments. Dr. Srinivasan? Okay, move on. Right.
On to the next.
Yeah, I'm listening. Yeah, going on well. So you have been asking all the questions. So
Right.
let me not ask some more questions. Yeah,
Right.
proceed.
Right. Dr. Hamapriya, please don't show the investigations till we arrive at clinical diagnosis. You have not completed physical examination.
Yeah.
Please don't show the investigations, even though they may be of past.
So coming to the general physical examination, the child was examined in sitting and sleeping position after the child was stabilized. So initially he had come with severe respiratory distress. So bilateral pleural tapping was done. After that, when the child was stabilized, he was examined. So he was conscious, alert, and oriented at the time to time, place, and person. Coming to vitals, temperature was normal, heart rate was 98 beats per minute, pulse was measured in the right radial artery, right femoral artery, and carotid artery. It was 98 beats per minute, regular rhythm, normal character, normal volume, no radial or radiofemoral delay, and other pulses were well felt. BP was measured in the right upper limb in the sitting position, and it was 112 by 70 mm of Hg, which was on the 95th percentile for his age and height. And the capillary CFT was less than 3 seconds. Respiratory rate was 28 cycles per minute, and saturation was maintaining 95% on O2 by mask.
No, better tell what was the saturations on room air. That is important, isn't it?
Okay.
Not when the child is on oxygen support. That doesn't give complete information. Better mention on room air. Right.
Better you describe the child, because child has had so many recurrences, whether any steroid phases or their short stage. Just mention something about the general appearance of the child and I think then you mention all these.
Yeah. Probably in the next slide she may be.
Next slide, she's still.
Probably, right. Move on.
Head to toe examination, there is gingival hypertrophy noted and there are white patches over the tongue. There's dental caries and bilateral cataract is present and hypertrichosis is present. Clubbing of grade 2 is present. There's no periorbital puffiness, facial puffiness, or Cushingoid features noted. Abdomen distension is present in the upper quadrants and umbilicus is pushed down, and there is no pedal edema.
So what has happened? What has happened? Your take in general head-to-toe examination is?
Head-to-toe examination, there are like side effects of the steroid and also the cyclosporins, which is seen.
Yes.
But there is no edema, so the child is not in relapse now.
Right.
Coming to the anthropometry.
No, see, Dr. Hamapriya,
Some unusual
you
finding
describe
is
the
that
slide.
clubbing. How can you distinguish?
Sorry, sir?
You have
Clubbing,
mentioned
clubbing.
clubbing, So that's a rather unusual in even resistant nephrotic syndrome. How do you explain that? The rest of the things, of course, we can understand, especially hypertrichosis can occur due to some use of drug, specific drug. But clubbing grade 2 in a nephrotic syndrome, how you would this thing?
So he had like history of pleural effusions. Tuberculosis or any chronic lung diseases can also cause clubbing.
Okay,
But there is not even cough. There is no cough even, right?
So cough may not be there always in tuberculosis. because like he was on long-term immunosuppressive agents, the features can be masked, the fever, cough, and all can be masked.
You would have given the appearance of the child. You would have put the image of the child.
So in the next slide.
Yes, sir. Next slides are put it.
Right. Okay.
What is the meaning of grade 2 clubbing? What do you mean by grade 2 clubbing?
Grade 2 is obliteration of the nail bed, sir.
For Shamrod sign positive? Did you look for Shamrod sign?
Yes, sir. The obliteration of the space, sir, where we look for the
Did you do that? Did you do
yes,
Shamrod sign? You have a picture of the Shamrod sign of the side?
Yes, sir.
See, two things. I'll tell you. This child who's got anasarca, grade 2 clubbing is not a very reliable sign. After all, you get interstitial edema.
So he didn't have anasarca.
No. See, this child has had long-term anasarca. So, right now, even if there is no severe anasarca, it's hazardous to...
it may be a pseudo clubbing.
That's what I'm trying to say. It may be pseudo clubbing. It may be pseudo clubbing rather than true clubbing. See, other than that, in tuberculosis, you don't get clubbing. Simple, uncomplicated tuberculosis, you don't get clubbing unless there is cavitatory tuberculosis or tuberculosis causing bronchiectasis.
Yeah.
Tuberculosis abscess. Otherwise, tuberculosis.
Yes, same thing I wanted to ask.
Doesn't cause.
Not cause. Tuberculosis is not a cause for clubbing.
Yeah. The only way I can connect clubbing and nephrotic syndrome is, of course, very usual. Amyloidosis. I don't know. I have not seen a case of amyloidosis in nephrotic syndrome. Dr. Maharsh.
Pediatrics, sir. Pediatrics.
Yeah.
8 years.
We don't see.
8 years.
Nephrologists might be coming across such cases. Other than that, grade 2 clubbing, I wouldn't take it very seriously in this child. Not significant. Right.
But Hamapriya, what's your take on anthropometric parameters?
Sorry, sir.
What's your take? What's your inference?
Anthropometry.
Anthropometry,
like the child is having chronic malnutrition because like the height is less than 3rd centile and also the weight is less than 3rd centile. So
that is there. What's your inference? Is it underfeeding or anything else and anything else? What are all the factors contributed to faltering in the height and weight?
It is because of like his long-term like history of recurrent infections and also because of the nephrotic syndrome.
One is underfeeding from the nutrition history. Second is chronic disease. Third is steroids for long time in irregular doses. Fourth is recurrent infections. Right.
Next slide.
Coming to the systemic examination, respiratory system.
Dr. Hamapriya, you have not shown the image.
Yeah, show the image. Show the image.
Just one comment. It's very unusual to find malnutrition in nephrotic syndrome. Very unusual. Run-of-the-mill nephrotic syndrome, children are well nourished. Even if it is recurrent nephrotic syndrome, they may suffer from growth retardation and short stature because of therapy, rather than severe malnutrition. The presence of so much of wasting indicate that there is a chronic systemic disease which might be responsible for the problems in the child, either causing nephrotic syndrome due to the disease or as a complication of nephrotic syndrome. That is what is the inference I will get if I see a child with nephrotic syndrome whose weight is also very much below the centile. Okay.
Usually with steroids, they feel so hungry, so usually they'll take a lot of more than the normal intake.
They're obese.
Yeah.
Sir, I just want to differ a bit here. In cases who are non-minimal change in nephrotic syndrome, they tend to have malnutrition. The reason is because of the immunosuppressives, and they lose lot of IgG, lot of proteins in the urine, which makes them susceptible to frequent infections. And these people are at risk of developing severe malnutrition. And we have seen a lot of children who are not the minimal change, not the first episode, but subsequently when they go for dependence and resistance, they tend to develop malnutrition mainly for recurrent infections, and because of the toxicity of the immunosuppressant, they're not able to take in food, and the edema gets masked. The edema which they have gets masked, and we don't realize the malnutrition in these patients. So we need to keep a very close eye on those patients who are dependent and frequently relapsing and steroid resistant for malnutrition. We need to keep a close eye on these children.
Agreed. In other words, it's not the nephrotic syndrome which is causing the problem. It is a chronic systemic disease, either iatrogenic or in associated nephrotic syndrome, which causes the growth retardation. Basically, minimal change disease does not cause growth retardation except in height if they are given steroid. In terms of weight, they do very well. The very fact that the child has suffered from growth retardation, both in weight and height, indicate it is beyond minimal change disease. That is what I was trying to tell.
Correct.
We go back to the previous slides as per your plan, right?
Coming to the systemic examination, respiratory system, upper airway, the ear and nose are normal. Oral cavity, there is gum hypertrophy, dental caries, and white patch over the tongue. The gum hypertrophy is because of the cyclosporin which is taken. And the white patches may be like it can be candidiasis because it is immunosuppressed. And throat and the oropharynx are normal. Coming to the lower airway, on inspection, the trachea appears to be central in position. Apical impulse is seen in the intercostal space in the mid-clavicular line. There are no scar, sinus, or engorged vein seen. And the respiratory rate is 28 cycles per minute. Abdominothoracic type of breathing. There's no use of any accessory muscles. The chest appears to be symmetrical, and the movement is reduced on the right side. On palpation, the significant findings are the hemithorax. The right side is 28.5 centimeter, and the left side is 27.5. So there is increase in the hemithorax measurement on the right side. And also the chest expansion on the right side is reduced, and tactile vocal primitive, it is reduced in the bilateral intra-axillary, intrascapular, and on the right side interscapular and the axillary areas. Coming to percussion, there was dullness present in bilateral, intrascapular, and intra-axillary areas and the right interscapular area. On auscultation, there was air entry reduced in bilateral, intrascapular, and intra-axillary areas, and right side axillary and the interscapular areas. There were normal vesicular breath sounds which were heard. There were no any added sounds. So all the findings, it is suggestive of bilateral pleural effusion, which is more on the right side as compared to the left side.
Just for the sake of completion, you would have mentioned about VF and VR and shifting dullness. Okay. We know it is effusion, but still for completion to be more religious presentation. Okay.
Coming to findings, it appears to be distended in the upper quadrants, and umbilicus is pushed down and it is at level. So this can be due to the bilateral pleural effusion, which is pushing the diaphragm down and the liver and the spleen down. So there can be upper abdomen distension, which is noted. And all the quadrants move appropriately with respiration. There's no scar, sinus, or engorged vein that is seen. And the genitals appears to be normal, and there is no scrotal edema that is seen. And on palpation, there is no local rise of temperature or tenderness. Abdomen girth is 48 centimeter, and liver is palpable 3 centimeter below the right costal margin. And there's no palpable spleen or any other palpable mass. Percussion, there is dullness, which is present in the right and the left hypochondrium and in the epigastrium. There's no shifting dullness noted, and the liver span couldn't be measured because the upper border couldn't be exactly made out. And on auscultation, the bowel sounds were heard normally. Cardiovascular.
No, just a minute. Sorry to interrupt you.
Specifically, you have to mention spleen also, because in occasion, if a spleen tip is palpable, it could be a systemic lupus, erythematosus, diffusion, etc. And you said hypertrichosis and other gum. So it's better you mention about specifically spleen not palpable. Okay.
Yes, also spleen.
I have mentioned, sir, no palpable spleen.
You may mention about whether presence or absence of abdominal wall edema. Okay, presence of abdominal wall edema is suggestive of
it can be due to like the anasarca and also because of the.
No, don't say anasarca. Anasarca is depending on the extent of the edema. It is nothing related to abdominal wall edema alone. Suppose there is abdominal wall edema, what's your take?
It can be because of the infections, sir, of the.
No, it is suggestive of nephrotic syndrome, which is hypoproteinemic condition. The hypoproteinemia of nephrotic syndrome and nutritional cause may cause abdominal wall edema. In contrast to hypoproteinemia or hypoalbuminemia that is seen in cirrhosis, where you don't see abdominal wall edema, even though there is hypoalbuminemia. Okay. So you have to look for whether the abdomen skin is shiny, and on palpation and pressing over, you see whether there is indentation, which is suggestive of abdominal wall edema. Again, it is one factor to say it is nephrotic syndrome. And comment on the posterior abdomen. Right? Even though something is there or not, for completion's sake, you mention all the headings.
Yes. Coming to the following course in the hospital, in the following days, the air entry again reduced and the distress increased, and repeated X-ray showed like increasing in the pleural effusion. So a bilateral ICD was placed and pulmonology opinion was taken suspecting chylothorax. And the pleural fluid analysis was sent, which was suggestive of chyle. This is the pleural fluid, which appears milky white in color. So, following this, the pediatric surgery opinion was taken and HRCT was done, which showed bilateral gross pleural effusion with collapse of the underlying lung segments. In HRCT, there were no like enlarged lymph nodes that were like noted. And then the plan was for surgery after confirming from where the leak was from the thoracic duct. And so intervention radiology, the lymphangiography was planned, but it couldn't be done because like all the lymph nodes were small. So the dye couldn't be injected into the lymph node. So a lymphoscintigraphy was done where the dye was injected into the web space in the bilateral lower limbs. And following this, like there was like confirmed presence of the chylothorax. It showed like a accumulation of the like a dye in the right hemithorax. So a CTVS opinion was sought, and they advised for conservative management. So diet modifications were done when like a low fat and MCT based diet was given. So the background of this is that the MCT, the medium chain triglycerides, we can use either the MCT oil or even for like cooking purpose and all, we can advise the mother to cook in coconut oil. So this one, like it doesn't go into the lymphatic tract, it directly like goes into the portal circulation. So the amount of fat which is going to the thoracic duct and the contents reduce. So the chylothorax also reduces, and bilateral ICD was in situ, and it was like the drain was like monitored. Following this, like the drain could gradually reduced over the next few days from like around 500 to 600 ml per day to about 50 ml per day. And then the ICD was removed in view of high suspicion of tuberculosis, because the child had like history of tuberculosis also previously. So he was started on ATT, and then the patient improved and he was discharged.
Did you try for microbiological confirmation?
So we had done like CBNAT and also ZN staining, but both were negative.
CBNAT on CBNAT on?
CBNAT on the pleural fluid and also the gastric aspirate was done, sir.
No, CBNAT pleural fluid unlikely to be positive, but gastric aspirate it turned to be negative.
Gastric aspirate was also done, sir. That was also negative.
And now we will see the X-rays.
Did you do IGRA for this child?
IGRA we are not done.
Yeah. In fact, for this child, of course, the tuberculin test is of no use. If IGRA is negative, tuberculosis is very, very unlikely, even though, of course, CBNAT you look for, AFB you look for. If IGRA is negative, it would go very much against tuberculosis as a cause of this sort of chylous ascites. Of course,
Did this yes?
No, IGRA, interferon gamma release.
I'm just asking, was there any chylous ascites too in this child?
No.
Or only pleural effusion?
Chylothorax.
Chylous. Yeah, chylous.
So it can be lymphangitis also, no? So we do not know whether it is really TB? How much it is pointing towards TB when it's bilateral effusion?
Yeah,
I'm not very sure that whether it's
Bilateral
tuberculosis.
effusion is not much suggestive of it being tuberculosis origin.
Basically we had not started this child on ATT for nearly 6 months, in spite of recurrent admissions for pleural effusion, because we thought it should be chylous ascites only, chylothorax. But in view of severe malnutrition and having on immunosuppressives, we lastly had to add on tuberculosis, but we had no other choice, in spite of all the investigations being negative for tuberculosis. That was clinical.
What about HIV? HIV in this child?
Everything was negative, sir. Everything was negative.
Shall we see the X-rays, Dr. Hamapriya, now?
Yeah, sure.
This is the time you shall go, sir. After clinical examination only, you tell the investigations. All right. Can you read for everyone else?
Yes, sir. The first X-ray, it is showing, it is a PA view of the chest and the abdomen, and like it is a good exposure, and the trachea is in the midline, sir. And also, like, there is bilateral costophrenic and the cardiac angles are blunted, sir. And there is homogeneous opacification seen in both the sides, sir. So it is more suggestive of bilateral pleural effusion.
Okay. This is after.
And the second X-ray, sir, it was like a post pleural tapping. Bilaterally pleural tapping was done. So there is on the right side, still we can see the effusion, but on the left side, it has comparatively like improved, and we can see the costophrenic and the costocardiac angles over here.
The thing, sir, initially we did not go for ICD. We thought it as a phenomenon of nephrotic syndrome causing effusion. So we did not go for bilateral ICD. We did pleural tapping repeatedly, but in view of repeated recurrent effusions, and once we came to know it's very milky, then we had to stop and we had to put bilateral ICDs.
Must have been very tough on you. Must have been very tough on you, I'm sure.
Very tough, very tough.
Agreed.
The child was on HFNC for nearly 1 week. High frequency, very. We should appreciate the parents' compliance and the patients, because they stayed for nearly 2 months in the hospital, and the child also was kept in the charitable emergency hospital, where hardly any charges, hardly 100 to 200 rupees we charge. So that's a very advantageous thing what we have at our hospital, so that the other cost could be used for other investigations. So we should thank the parents for being very patient and compliant all throughout the stay for nearly 2 months.
So currently the child is on ATT, and on 27th of September he had come for follow-up, and he's doing well now. There is no history of any fever, breathlessness, or pain abdomen, edema, or jaundice in the child now. Coming to the problem.
No, I should not use that word, but the case is very good case. Good in the sense for learning, not for the child and parents. Right.
So coming to the problems that the child had, he had steroid dependence initially with frequent relapses. And also he had like adverse effects of long-term steroids, which was like cataract, repeated infections, and also hypertension. And complicated relapses were there, which were requiring ICU admissions, LRTI, SDPs. And he also has chronic lung disease, repeated chylothorax, suspicions of tuberculosis. And also he later on like went into like FSGS and steroid resistance. And so cyclosporin was started, and following that he had like side effects of that, which were hypertrichosis and gum hypertrophy. And also the child is having chronic malnutrition due to repeated infections and the nephrotic syndrome itself.
Just a minute, Dr. Patil. Shall we call it is steroid dependent and as well as frequent relapser? Do they go together?
some of them have, so like for example, initially they are steroid dependents, and once they start having the features of steroid toxicity, they tend to have frequent infections, and then they become frequent relapses. So these are the indications where you have to do see for steroid toxicity and do a renal biopsy, so that you need to come down on the dose of steroids as soon as possible and put them on alternative medications. The problem what we face is that the alternative medications are expensive, sir. So we try not to, at least in with me, I try not to do renal biopsy to a greater extent, because putting them on alternative medications is not easy. The cost of mycophenolate is very expensive. One tablet is on 25-30 rupees. They have to be there for nearly 1-2 years. So we need to see that we need to put them on the lowest dose of prednisolone to try to get them into non-steroid toxicity features and keep them in remission for a longer duration, 6 months to 8 months to 1 year. Try to achieve that, and then use the drug which is cheap, that is vermisol, which helps in frequent relapses but does not help in steroid dependence. So we try to do that to a much greater extent in our institute.
Can I ask one question, sir?
Yes, sir.
Can I ask you a question, sir?
Yes, yes.
So if the child happened to be a female child, okay, with ascites, etc.,
Yes,
and this thing would do then investigated for SLE or something without skin manifestations or anemia. So would you have like to do something to look for ANA, etc.?
yes, sir. If a child is having suspicion of female child is having suspicion of SLE, sir.
Yeah.
Yes, we have to do a ANA in this.
Because I have been attending rounds by
Is there something else I can help with?
So we need to rule out in such cases SLE. We do ANA and TSD.
Yeah.
We do. And then do a renal biopsy. If they have lupus nephritis, if they have proteinuria which indicates that the child is having lupus nephritis.
One clue to the possibility of lupus in such cases will be an altered C3 level.
Yes, sir.
Of course, lupus can also cause membranous glomerulopathy without nephritis, but usually if it is classic lupus, the C3 levels will be low. The other comment I wanted to make, in this child who, tuberculosis coming after 1 year of intermittent steroid therapy makes things unlikely. Tuberculosis being unlikely, even if it is tuberculosis. That's number one. Second, if it is tuberculosis, if it is proven tuberculosis, in this child who's having malnutrition, who's behaving unusually with nephrotic syndrome, I will think beyond tuberculosis and also do an immunodeficiency workup with this child. Simply not blame only the drugs for the infection. That makes me ask Dr. Hemapriya, what is the mechanism of infections? What are the various mechanisms by which infections occur in nephrotic syndrome? Pathogenesis of various infections in nephrotic syndrome. What are the factors? It's not simply one factor, multifactorial. What are the factors? This is a standard exam question we ask.
And it's like because of the loss of immunoglobulin, sir.
Which immunoglobulin?
IgG, sir.
Low molecular weight. Very good. One.
And also, like, there is loss of the complement factors also. That will make the child more prone for the encapsulated.
Okay.
And the third one is like the child is on the immunosuppressive drugs. So that can also
steroid therapy. 3, 4.
One more is
opsonization. Anything related to
opsonization?
They lose
edema.
They lose propyridine in the
factor.
This is also why edema acts as a culture medium. 6. when they have massive anasarca, you must remember there is a lot of interstitial edema. There is hypovolemia, which causes functional hyposplenism. Functional hyposplenism. Okay. And many of them, if they have too much of anasarca, they are given undue bed rest, which makes them more prone for infections. Last but not the least, nephrotic syndrome basically is a T cell disorder. T cell disorder. That makes them react to even viral infections abnormally. So these are all the mechanisms by which nephrotic syndrome children are prone to develop not only bacterial infections, but also viral infections. Viral infections. Okay. My last question to you. Would you have considered penicillin prophylaxis for this child? In fact, sir can answer, Mahashet, in his unit, in a child like this, who's getting immunosuppressives, who's getting a lot of immunosuppressives, cyclosporin, etc., would you consider penicillin prophylaxis for such children on a long-term basis, and do you give in your unit?
I think Hemipriya has not gone through the OPD file properly.
He
This
was
child,
on penicillin.
child was on pentids, penicillin prophylaxis for quite a long 2 to 3 months. We give some week.
Dr. Hemipriya, which vaccines you advise for this child if they can afford?
So we will have to give the vaccine, pneumococcal vaccine, then meningococcal
No,
vaccine.
you clarify. Pneumococcal means?
Pneumococcal vaccine, like we will have to give the polysaccharide vaccine, sir. So it depends basically on the age of the child and whether they have been like previously vaccinated also.
No, they have not. Conjugate vaccine was not given. PC was not given.
Okay, so if it was not given, then we can give 2 doses of conjugated vaccine 4 weeks apart. Following after that, after 8 weeks,
it is 13 valent, 1 dose will do.
1 dose.
Right, 13 valent, 1 dose will, followed by
conjugate vaccination. We will have to give after 8 weeks, sir. And when this vaccine is given, the child should be in relapse, sir.
One more question I want to ask: is renal biopsy being planned, or it will be deferred for
Done.
FSTS. Done, sir.
Done.
Already done.
FSTS.
Yeah. That's
Was an HRCT done for this child? Would it
Yes,
have helped in getting some
We have done HRCT, madam, in this child.
chest CT?
Yeah. She had.
Yes, did it show any note, anything?
what other vaccines?
So we can give influenza vaccine yearly should be given to the child. And
Regarding the chickenpox vaccine, varicella vaccine.
Varicella vaccine to be given.
To whom? To the child or for people around?
To the children and also the people around also. So the siblings should be given. When the child is having yes, sir, for the siblings also it should be given, sir.
Why siblings, family members?
So because like children are more prone for varicella, so it's like transmission from them to the children. It's basically transmitted by droplet infection. So even if they are like vaccinated, it provides a herd immunity basically.
Basically, you must remember, anybody who receives steroids more than 2 milligram per kg for more than two weeks, you should not be giving live vaccines.
Attenuated vaccine.
One vaccine which can be given is one vaccine which can be given to all these children is influenza vaccine. Right? Remember the rule of 2. And similarly, live vaccines can be given 1 month after stopping all the steroids. 1 month after
The remission and after stopping.
Alternate day steroids, you can give any vaccine. It's not a problem.
Sir, what's your experience with regarding levamisole?
Sir, it's an excellent drug side.
Because most of the textbooks, they don't deal much about it. Because levamisole is not available in some developed countries also.
Right. The reason is because it's very cheap, sir.
Yes.
Granulocytopenia, they have afraid of that. No. Yeah. That's one of the reason it has gone into disrepute.
We use it very.
Of course, because used.
We don't
being used.
We don't do CBC also. Once
Yeah.
in 3 months, once in 4 months, they come. We don't even do
Yeah,
that. Just see clinically. It's a very, very nice drug, sir, but it has to be used very nicely.
yeah. Previously, we were using.
Yes, it's very nice
Yeah.
drug. It's useful for frequently relapses. Excellent. It's a very nice immunomodulator. It brings down the recurrent infections to a great extent.
Along with steroid, isn't it, sir?
It has to be used along with steroid and try to taper the steroids as slow as possible because it's a very mild drug. So you cannot taper the steroids very fast. It has to be, counseling has to be done to a great extent to say that steroid toxicity will occur in a child who is having vermisol, but we need to counsel them and tell that we have no other option. We'll slowly taper down the steroids and not taper it rapidly. Otherwise, it will again the child going to relapse.
Why cyclosporin was selected here, sir?
Sir, Dr. Mahantesh, when do you do genetic studies in such patients of yours?
Yes.
What do you do?
Yes, sir. So usually, if there's a genetic history, we do, sir. One, if there is a history of nephrotic syndrome in the family, we do genetic. The other important thing is once they have steroid resistance, primary steroid resistance, absolutely first episode, no responsive, 4 weeks, 6 weeks, no response, we do genetic. So we send for whole genome sequencing and we look for mainly for the NP. What we have got is mainly at NPHS1 mutations frequently, and for less than 1 year of age, we it's indicated to do genetic studies. Less than 1 year who present and more than 3 months of age who present with infantile nephrotic syndrome, we do genetic analysis, and any of them have shown this NPHS1 and NPHS2 mutations, which will help us to tell the parents, counsel the parents that immunosuppressants may not work in this child and the progression to chronic kidney disease is will happen. And then also it helps us to counsel the parents to a much greater extent when we do this genetic analysis.
What is the rationale of selecting cyclosporin here, sir? When it was responding to steroid.
So this child actually, we started on initially when the child had frequent relapses, we started on vermisol. So I usually go by that protocol. I start with vermisol and then go for more than 8 years. We usually use cyclophosphamide, sir. Yes. 8 years we don't use because it does not help at all. So in this child, we had not used cyclophosphamide. We used vermisol. In spite of that, the child did not respond. Then we had to go for mycophenolate, which hardly any response. Then we had to proceed for renal biopsy and then start on cyclosporin. The reason is from our experience, the focal segmental glomerulosclerosis responds much more better to cyclosporin than to other calcineurin inhibitors like tacrolimus. That's the experience what I have, sir. Okay. And in many centers they differ, but here the response to cyclosporin is much better, and he responded very well to the cyclosporin.
Dr. Subramanian, sir, your comments, final comments. Dr. Subramanian, your final comments.
Because there are two Subramanians, one Bala Subramanian, so they are wondering whom you are asking.
My God, I thought you were asking Dr. Subramanian.
Is he there? Subramanian sir is there?
Yeah, excellent.
He is not there. He is not there.
Yeah. Sorry. I thought you were calling Subramanian. Thank you.
Subramanian is not there.
Anyway, all I have to say is that it was a very good presentation by Doctor, I forgot her name, sorry.
Hemapriya.
Hemapriya.
It was a very good presentation. Yes, and of course, very nice discussion by Dr. Mahantesh. I also learned quite a lot. A very unusual case. All I have to do is to give compliments to the team for the nice learning opportunities for senior citizens like me. Thank you very much.
Dr. Srinivasan?
Yeah. Really a wonderful case, well selected, and of course, It's very informative and we all learn every time. Yeah, it's a very instructive case. And of course, I am regularly attending Dr. Sriram's rounds. He is a pediatric nephrologist in JIPMER. So he is having a good number of cases of focal glomerulosclerosis. And he's a brilliant pediatric nephrologist trained in St. John's. So it is really a blessing to attend his rounds, and each and every case is instructive. And this is also another instructive case which has given so much of input, especially with Kairos societies, etc., pleural effusion, etc. Thank you.
It's a case is very good. Only thing is, you have done, Dr. Hamapriya has done well, but you should have given us the clues regarding the diagnosis initially. Let it be in the title or in the history of present illness. There should be some, it should be wrapped up. And then only after clinical examination only, the investigations and all those things. That would have been better, especially in the exams. If you give the clues in the history of present illness, that implies that you are told the diagnosis beforehand by your juniors, right? Barring that, you have done good job. And Dr. Patil has done well. Thank you, sir. And Dr. Sarah, ma'am, it's your final comments.
I'll just
It was a good learning case, although, yeah.
I'll just tell one thing, sir.
Yeah, yes, Mandish. Yeah.
I would like to thank all the respected teachers and faculties, because it's a great learning experience for me to learn from such stalwarts in the field of pediatrics. It's very, very nice to see them and learn from you also. It helps us it inspires us to do much more better in the future and take care of these children to a much better extent in the best possible way, and see that they don't suffer from any other toxicity features. That's what we learn from you all, sirs, madam.
It's very kind of you to mention that each case is instructive to us, and we learn, all of us learn at the same time.
Thank you, sir. Thank you, sir.
Yes.
Sarah, ma'am.
Yeah, it was same. I also echo the same feelings. I also learned a lot. It was a good instructive case. Yes, Ramakrishna sir. The presentation, I think probably she made it as a summary. It was not like the exam type of presentation. She might have deviated a bit, but I think that was just to bring out the chronological points in the case, and the other things. It was an excellent case, good, especially with the Kairos societies, a lot of distractors, whether TB, not TB. Still, I wouldn't be surprised if it does not turn out to be TB.
You're right, man.
Because there were no lymph node enlargement even.
There is always surprises.
Yes,
you must follow up. I'm just saying this child should be followed up for 6 months or later. God knows when I'm going to stop the AKT, whether it's going to recur. And still that doubt really remains in our mind. Is it really TB? You are fully justified in starting AKT. I'm not saying that. But we've had a couple of patients with lymphangiectasia and all. They all got treated like TB. They all turned out to be something else. So don't forget that.
We'll keep that in mind. Thank you. Thank you.
Yeah.
Thank you all.
Thank you all. Very good night.
Okay. Good night.
Good night.
Thanks, Dr. Mahantesh, and
thank you, sir.
everyone.
Thank you.
Wish you all the best, Dr. Hamapriya. Wish you all the best.
Thank you, sir.
Thank you.
Right. Good night, all. Right.
Thank you. Good night. Thank you, madam. Thank you.